Good afternoon, everyone. And at the outset, I would like to thank Dr. Haldipurkar sir for including me in his IC. And yeah. Yeah. And I would also like to compliment Dr. Haldipurkar sir that this is a totally different and a unique topic, because we have all heard of general topics on cataract, refractive glaucoma, but this is something which has been so unique because we have gone through a very unique and a once in a lifetime kind of situation in the last 2 years. So let's see what I have learned from the corona pandemic. Life isn't about waiting for the storm to pass. It's about learning how to dance in the rain. So we all have faced a very overwhelming situation with the entire country going under a lockdown. And yes, as ophthalmic surgeons, we faced also a very unique problem in the sense that our cataract patients, which are our bread and butter, just simply refused to come. One, because the inability to come because of the lockdown, and two, because cataract being an elective surgery, the patients had a very easy option of postponing the surgery. The problem was that because of this, we all saw an overwhelmingly increase in the incidence of lens-induced glaucomas, mature intermittent cataracts, very hard, dense cataracts. So all of us have seen this, and I believe all of us have found this change. Now, nothing in life is to be feared, it is only to be understood. And now was the time to understand more than any other time so that we may fear less. So this was an opportunity for us to hone our skills at the hard and complicated cataracts that we saw. So here you can see, suppose you have an intumescent cataract like this. The first thing is when you're doing a manual rhexis, you can use different techniques because there is a very high incidence of Argentinian flag sign. So here we are using the spiral design. So you refine your capsular rhexis in a way so that you get a good, adequately sized capsular rhexis, but at the same time you prevent an Argentinian flag sign. This was another hypomature intumescent cataract with a toric IOL. So here we are planning a very small rhexis, say a 3 millimeter rhexis in the beginning. The aim is that you first make a small rhexis and then decompress the capsular bag. So here, because the intralenticular pressure is much higher, if you start from the periphery, it very easily runs out to the periphery and you can have an anterior capsular extension. So here, you first make a small rhexis and then I'm actually using an irrigation aspiration to aspirate out some of the loose cortex, and so the bag is the decompressed, and then you have a nice high molecular weight viscoelastic, flatten the anterior capsule, and now we have made a nick with a micro scissors, and with a 23 gauge microforceps, we can extend this. And this gives us now an adequately sized capsular rhexis so as to facilitate a proper phaco and the rest of the surgery. Now, we also made use of the Zepto technology, which works superb in such cases. And here we are using a multifocal intraocular lens, as you can see, with absolutely perfect centration, and it gives very good visual outcomes too. So we also have access to the flax in our center, so it works well to give a very good rhexis also in intumescent cataracts, and definitely you can use premium lenses also. So these were the various things that you can actually go at, and we had enough and more opportunity here in case of the COVID times. And yes, all our patients face tremendous problems in their economic conditions and the demand for discounts at every step. The problems that we as surgeons had to face with use of PPE kits, the risk that we were exposed to because of the aerosols, and the RT-PCR tests that we needed to have our patients getting done. So these were too many things, and we had to have really a very brave heart to face all this. So now there was this good, nice paper on will COVID-19 change our thinking about the timing of cataract surgery. And yes, though otherwise we would not have probably thought about this, but in this unique period, probably doing a sequential bilateral procedures, especially for those patients where the coming and commuting to the hospital was difficult, could be one of the options. And yes, we all had the sanitizers, the masks, and the social distancing to be followed. Now, an interesting article here was wearing face masks becoming a higher risk of endophthalmitis, especially in intravitreal injections. And probably this could also, extend to cataract surgery. And the challenges here was basically the dispersion of the airborne particles towards the eye when the patients speak or even breathe. So most importantly, because of the mask, it probably impedes the proper preparation of the periocular area, and there could be a contamination of the surgical instruments with the mask, with the surgeon's glove. Now this is a very interesting picture, and if you can see the 3 pictures with the arrow, you can see these are the video frames which demonstrate condensation of the breath on the intraocular lens. So this is really scary. So if at all this actually happened or could happen today, even today we are using masks in our ORs. So I think this is something which we need to keep in mind. So what we basically learned is how to tape the face mask onto the patient's mid-face prior to all ophthalmic surgeries, especially the intraocular ones, to reduce air leakage. So learning how to drape is an important art which you should not trivialize. So here you need to dry the patient's skin, press down firmly, and ensure a complete seal with an adhesive tape to prevent the spread of infection. Now again, the cataract service was also redesigned, not only in all over the globe, but also at our center. And yes, there were a lot of webinars. Also as part of the ARC, we conducted a large number of webinars and learned a lot number new techniques. If you saw the number of patients who were diabetics, and yes, because all our outdoor activities and even the walking had reduced, there was a high incidence of diabetic retinopathies and the cataracts in post-diabetic patients. So you needed to counsel these patients, and we all remember having such social distancing and wearing of the face shield and all that. So these patients were already so tense and with their economic problems and the complicated cases, our counseling also had to be redefined. Now, if you look at the challenges of wearing face masks, something I would like to share with you is there was not only an increase in the incidence of dry eye, but yes, you will all relate to the fogging of glasses. All of us who are wearing glasses would also relate to it. I would like to share with you a unique mask-related femto-LASIK complication which we had experience. So if you can see here how with each breath of the patient, you can see how that steam is going up and down of the breath, and you can see we are doing an intralaser here, but there was no penetration of the femtosecond laser. So the laser actually, we stopped it because it couldn't be completed, and we went ahead and did completed it on another day. And this was also published as an online case report in the JCRS in Jan 22. Now, there are a lot of mask-related causes of the dry eye. The most important is there is increased breath that is coming out from the top of the mask. Yes, using lubricants, ensuring that your mask fits well, and then other environment-related changes that you can make will help. Digital eye strain and ocular surface disease was also on the rise. This was a very interesting article where they compared a face mask-related ocular surface modification along with changes in clinical in vivo confocal microscopy and immune cytology studies. So the purpose of this study was to describe how the face mask actually causes changes on your ocular surface, and the results are really very scary because the mask use is still on today and we never know when the next wave hits us. So what they did was compared a first group of dry eye disease patients, known dry eye disease patients, with healthy subjects, and they divided into 3 groups: less than 3 hours, 3 to 6 hours, and more than 6 hours. And what they found was, at all these patients with the dry eye, especially the T-BAT, the fluorescein stain, all of them were significantly affected. So for example, you can see more than 6 hours, you can see how the lissamine stain is also increased. So today we are, as surgeons, we are using face masks throughout the day. So we all need to get our eyes checked for a dry workup, I believe. So there was a dendritic cell density and HLA-DR also positivity, which was significantly higher, and a reduction in the goblet cell density too. So these were all actually proven. So this means that we all need to worry and take care about the dry eye patients that we already have. So for all our cataract surgery patients, we started doing a dry eye workup during the corona pandemic, and that was what that we learned. And also modify the surface with medical and behavioral strategies. Detect and treat early was what we learned. use lubricants and also IPL treatment and monitor them regularly. Even a simple refraction that we did for our post-cataract patients, because of the lens fog, many times they just thought that they were not able to see when actually the trial frame was getting fogged. Even those patients who are on anti-glaucoma medication, you can see that because of the mask, there is not only a fixation loss rate, there are artifacts because of the mask. So we need to be very alert to these conditions, especially in our glaucoma patients too. And all these small things like mask wetting not only and staining, not only in the OPD but also in the OT, actually could cause small problems to our patients. So the take-home message is we need to be more alert, more aware, not only in our OPD for our high-risk groups of dry eye and our cataract surgery, refractive surgery patients. We need to counsel them, detect early, treat early. So what we learned was to be resilient, which means advancing despite adversity, and we also need to upskill ourselves. So we took that opportunity to upskill ourselves and our staff and our doctors for this. I would just like to share one thing with you, that it's not just being resilient, but also being anti-fragile, where you gain from a disorder and not just bounce back after an event has happened. So never stop learning, because life never stops teaching. Thank you so much. So even as a crisis drove us apart, we healed by coming together. Thank you so much.
Thank you, ANAGHA. I just want, by the way, my friends, if you all have any questions related to anything, please feel free to ask. I start with the first one. ANAGHA, you showed Zepto and you showed Zepto real fast. That was very good and very impressive. Tell me cases where you cannot or should not use Zepto?
Subluxated cataract?
So you obviously,
no.
Maybe presence of vitreous?
Definitely. Presence of vitreous we cannot.
Otherwise,
but even in a small pupil, I've used iris retractors and I've used Zepto.
Okay. What about extremely fibrotic capsule? That's where it is more indicated.
Yes, it will be difficult, but then nothing would work, not even flax. So in such cases, you need a scissors. I mean, so even the manual Rexis would be difficult.
But have you ever tried in very fibrous capsules?
So if it's, usually in a fibrotic capsule, there would be areas which are still clear. So in those areas, it might cut. But in a very thick fibrotic plaque, it would be difficult. So maybe you can use it as a template and then fashion out the rest of the Rexis.
How many among the delegates or attendees are using Zepto? None. Okay. So you have any questions?
So ma'am, since you found out that there is dry eye that's much more prevalent now, is there any protocol that you have started that, obviously the ones that you have detected dry eye, you would treat them, but otherwise, do you start any lubricant pre-op, and which
Definitely. See, especially for our premium IOL patients, if you're planning a toric, for example, and a patient has a poor ocular surface, your keratometric readings are not going to be perfect, and you need to repeat and see whether you're getting consistent readings or not. You can go completely haywire and you can end up having a residual astigmatism. When you're planning a multifocal IOL, your patients will come back to you with complaints of dry eye, even if you're 6'6" and 6. So more than ever, today is the day when you're going to have a highest incidence of dry eye. So we need to be very alert, especially in these premium IOL patients.
So is there a molecule you prefer to put?
Yes, we usually use sodium hyaluronate. That works best. But in cases of moderate to severe dry eye, we have also done an IPL first, pre-op, and especially in the refractive surgery group, I would definitely recommend each and every patient to do a complete dry eye workup.
Yeah. Thank you so much.
Thank you so much, sir.
Thank you. Yeah, please.
Hello.
Yes.
During manual Rexis in mature cataract, you first did a small Rexis, and then you debulk, and then you enlarge it. So why don't you debulk whole nucleus and then enlarge? Because if something goes wrong while enlarging the Rexis, it will go haywire. So better to do whole lens removal and then enlarge the Rexis.
See, what Rexis I had shown was quite small. So what you mean to say is to do a complete phacoemulsification, and then if it was a slightly larger Rexis, I would do that. We have done that in certain other conditions. But here I didn't want to go more bigger, because then there was a higher risk of going to the periphery. Here, I started and it was planned in such a way that it would be around 3 millimeters. Debulk just to get a flat anterior capsule. See, you cannot go too deep inside the bag also, because otherwise it can, pull on the zonules. So here it was big enough for us to decompress, and then it becomes a very controlled extension of the rhexis. In case the cataract was not so intumescent and you have a mid-sized rhexis, you can go ahead and do a phaco. And then when you put in the lens also, you can, even after putting in the lens, sometimes we have extended. See, you don't want a capsular phimosis at the end, but at the same time, you want a very controlled phacoemulsification.
My idea is just to enlarge the rhexis after removing whole nucleus. Because, nucleus anyway is very small in mature cataract. So better to remove whole nucleus and then remove, because if something goes wrong by enlarging the rhexis, it may go in the periphery and then create a problem.
Yeah,
That's
it
what I
makes
believe.
sense. Yes,
Okay.
it makes sense. Yes. Thank you very much.
Thank you.